at 70% of transgender population is being seen in that emergency department. And they may be deemed to have, we call it a red board case here, that emergent surgery when they're coming up, when you don't have that option sometimes to say yes or no. And so we want to be respectful with our team, but we also got to make sure that we are responsible for the care that we give to our patients. And I always say this, leave your luggage at the door at that moment.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
On this week's episode of First Case, we're bringing our season premiere guest, JD Buchert, back into the studio to discuss the topic of transgender patients and how to best provide care in a culturally appropriate way. Now, I know that this can be a challenging topic for some of us, and it can also get political very quickly, but that is not our goal today. Our goal, Chris, really is just to understand the patient, that person who is sitting on the stretcher in front of us, and discover how we can best provide care for them and be compassionate while we do it.
Absolutely. And it's the human in me is taking care of the human in you. And you deserve the absolute best in patient care. And that it's period, end of sentence. And so we have to learn how to do that. And that's what I hope everyone gets from this conversation today.
Yeah, I think we'll walk away better educated than when we're starting. So don't go anywhere. We'll be right back with JD Buchert.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us again this season is the one and only JD Buchert, Director of Workforce Safety at Parkland Health in Dallas, Texas. And JD, thank you for being willing to join us yet again this season for another interview.
Gosh, it's such an extreme pleasure to be able to do this. I really, honestly, you guys give me a platform to where I can actually preach to the world, basically, on some of the things that we can do as healthcare providers to benefit our patient population, but also ourselves. So.
Yeah, well, and it's important conversations to have, and you are passionate about these topics, so you're the perfect guest to help educate us on the topic. And I really don't think you need much more introduction at this point. You're just part of the team. But just in case somebody might have missed our first episode, or maybe they missed you in season 13, which I highly suggest you go catch both of those and listen to them. But just tell us a little bit about yourself, but why don't you also tell us why today's topic is so important to you?
Okay. My name is JD Buchert. Obviously, she said it perfectly. Yay, thank you. I've been in the perioperative setting for about 35 years, but I've been in healthcare for almost 40 years. My journey started in medical school, of all things. I wanted to be a surgeon, and unfortunately, my wife passed away when I was in my second year of medical school, and the military was paying for my medical school. So when I had to drop out because I had a 9-month-old baby boy, we still had our obligation with the military. So that's where I think the best thing that ever happened to me started, is because that's when I became a nurse. I became a nurse in the military, and it has been a tremendous journey ever since. Both my son and I grew up at the same time, and it's been really spectacular. But I'm very passionate about safe patient surgeries and how we provide the best care we can to all of our population.
Absolutely. And as we dive into this topic, really looking at our transgender patient population, we're going to have a lot of different terminology and a lot of things that we talk about. So as we get into it, why don't we just start with understanding the words that we hear a lot and might not know what all the different terminology means?
Well, one of the reasons that I became so passionate about this is that I adopted a transgender daughter after she was abused by her natural family. She was beaten and kicked out into the streets when she was a teenager. So we took her in and we were able to adopt her. And then that's when we actually really started to grow our knowledge. And so that's why it becomes so particularly important to me, because it was something I'd never really thought of. And I wanted to make sure that I grew as a nurse, but also I grew as an individual, a human being, how we can provide the best care. And so as I'm in both avenues, yes, I am still a human being. I really want to make sure that we share what we can do to make the world better, right? And that's all we want. We want to make the world better. And so when we start to speak about gender and how we define it, it's a lot of times it's how they see themselves, how people see themselves, how others perceive them, and the behavior expectations that are set, and the interactions with other people. So when we start to think about transgender, that's just an umbrella term that people who choose to have a gender identity. And believe me, my world was opened up so much further than this, because I thought transgender was just a transition from one sex to another sex. And there's so much more that comes with this. With the gender identity is what they're feeling innermost in their concept of their self. And so, but there's also things that I didn't know what the terminology meant, was like cisgender. And cisgender describes a person whose gender identity aligns with that sex that they're assigned. So, and a lot of people didn't understand that, because the word CIS was in front of it, that it sounds like it may not be what it is, but basically you're talking about a straight individual.
Interesting. I didn't know that.
I didn't understand that term either. So,
but there's also like gender dysphoria, which is that clinically significant distress that's caused when a person's assigned gender is not the same as the one that they identify with. And then gender expression, we kind of already know that external appearance of one's gender identity, and then that gender transition and the process in which someone is striving to be more closely aligned to how they identify themselves. But then there's also that sexual orientation that comes with this also, because a lot of people don't understand that sex and this transgender can be two different things. They think of it as one thing. And it's not. It is two separate things. So as we're talking sexual orientation, that's inherent and durable emotional, romantic, or sexual attraction to other people. So, they have these things where these biological genders or gender identity, but also that gender identity itself, how they can be male or intersexed or female, but also that sexual orientation comes in to play also. It's a total different bubble. So we can have somebody that is having a gender identity reconciliation, I guess is a good way to put it, but also a total different topic could be sexual orientation. And so when we as healthcare professionals really start to focus on one of those bubbles and not the other one, that's when we start to become more open to the care that we can provide.
Well, in learning all of this, there's so much more to learn with even around the terminology and through that. But there's a lot of statistics about, this population of, human beings and very interesting facts that, we've learned and you've learned. Is there important statistical and data that you want to share with our audience listening today?
Well, I think for us in healthcare, one thing that's really important to know is that, over 70% of that transgender patients are seen in the emergency room. That's where they receive their primary care. So if we're
Oh,
working in
that's
that
awful.
perioperative setting, we got to think that the majority of those people that have to receive surgery are coming through that emergency department. And they have let that disease or whatever it may be fester up over so long that they are more in an emergent surgery situation now instead of something that could have been preventative before.
But why? I know I'm butting in as you're on a roll here. Why are they feeling like they need to use the emergency room for their primary care instead of utilizing other primary care options?
Well, a lot of it is harassment. Half of the transgender population that is going into any healthcare setting are having negative experiences. So when they start to see that and it becomes a consistent with them, and that gender affirming language is not used, and how they're not using clarity in their charting. So as somebody may identify as a female, but you continue to call him a sir or Mr. or something to that aspect, it becomes insulting to that patient. And even when we speak softly, not knowing how to address, we don't take responsibility for our flubs sometimes. And so those are the things that we want to make sure that we know about. I'm going to be touching on that more, but I always think of one thing when we're providing this care, we have to be open and honest about the affirming language. We have to develop those habits of applying that gender neutral language, but also to avoid those sexist topics, which is such as referring to an unknown nurse or a caregiver as she or he when we're in there. And so it becomes little things like that. As my daughter opened my eyes, I became more of an advocate for being one of the on that providing team for our transgender population here. Now, a lot of people don't know that there are 25 million self-identified transgender people in the world. And in the United States, we have 1.4 million self-identified transgender people. And a lot of people don't realize that it has, in percentage wise, the highest murder rate per capita of any group. And so when we get to thinking about some of this, a lot of people think that it might be that male to female that is the highest population that gets, physical violence and physical assault, but it's not. It tends to be the opposite.
Well, and that's what's reported. I mean, imagine how many cases go unreported every year and every day. It would be an astronomical number, I would imagine. Mm-mm.
Yeah. So you already touched on harassment, and as I sidetracked you on your statistics because I just can't wrap my head around, the why. Like I got to know why.
Yeah.
I mean, that was season 14, but still, I got to know why. But anyway,
we still do. Yeah.
We still do. I still, to break this down and to have this conversation to understand why, so that we can move forward, educated and better. But what other challenges, maybe that are unique to our transgender patients, what challenges do they face in the medical setting besides harassment?
In the medical setting, I think a lot of it is, I don't want to say any other word, but ignorance. And I think what it is, as we had stated before in a conversation, people become uncomfortable with the situation that they don't know how to address. And so tends to be when we are unsure of how to approach a situation and it's uncomfortable to us, we want to make sure that we don't have to deal with it. So we hand it off to somebody else. But what do we do if it's an emergent situation? As 70% of transgender population is being seen in that emergency department, and they may be deemed to have, we call it a red board case here, that emergent surgery when they're coming up, when you don't have that option sometimes to say yes or no. And so we want to be respectful with our team, but we also got to make sure that we are responsible for the care that we give to our patients. And I always say this, leave your luggage at the door at that moment.
I agree. When I worked in pain management, I'm actually just now remembering this patient. She was and correct me if I use the terminology incorrectly because that's not my goal, but to tell the story correctly, was a transgender female. And she was very tall, had been a male prior to the transition. So 6'2", 6'3", built like a man, but we still saw her in pain management. We took care of her, and her name on the chart was female, all this stuff. But when she would come into our clinic, our nurse's desk and station was at the front before you walk in and you get to the patient rooms. And, our nurses would giggle. They would roll their eyes. Oh my gosh. Those things. And it just, I guess, puts a real example to that idea of making patients feel uncomfortable because they can hear that. They see those eye rolls or the laughing or the, oh, whatever, those kinds of comments.
And you think that they might be hyper vigilant to that too, because it is part of their everyday world.
That's exactly what I was thinking. Is there a hypervigilance or a super sensitivity to any comment because they're so used to the judgment that they experience when they interact with other people?
Well, yeah, and especially in healthcare, that's why they wait to the very last, very most emergent situation before they go. Not everyone. I bet there are communities in the United States that are more progressive. I'm in the South, and in the South, we understand that there can be challenges when it comes to judging people. How's that? I'm just going to say it like it is.
That's a very good way to put it. We're all in the South. We understand.
Yeah. But, the thing with that is that this is again where we have to hold our healthcare organizations accountable because we don't want the ignorance to grow. We want to be able to compromise in some aspects, but make sure that we let the organization and the healthcare system grow in the right ways when it comes to the care of any of our marginalized patient population. Transgender is just one of those.
Well, and there were studies that were, that were shown about, certain minority populations not being heard and their concerns about their own bodies or, symptoms that they were experiencing, not being taken seriously by, healthcare providers. And then that leading to, horrible outcomes and complications in their care. And I would think that is going to happen to this patient population too. And especially if they're being seen by emergency, staff and physicians whose job is to, get in and get out, Gomer, if you will, from the old books. But there's no consistent care for them. And if you're not being heard and then you're not being appropriately identified and you're not being taken seriously, those things are going to combine and then you're not even going to feel safe to ever seek out care.
Well, it's also the fact it really is because you also got to think about that patient's lifestyle, right? That now we're having over 50% of our transgender population that can barely afford to pay their rent, can barely afford to sustain food, transportation, anything to that aspect. But then we get to think about over 80% of our insurance companies will not insure transgender population. So when they come into our healthcare settings, that's usually for a financial assistance situation or they just can't afford it. So they're going to the urban-based community hospitals because they usually will have programs that can assist them, but not in all towns and only in major cities.
Right. So what about if we flipped that script and looked at it from the other side? If in areas where there have been strides made in inclusive care and in being more educated in the ways that we care for our transgender patients, what have the effects been on psychological safety and on patient outcomes for this group of people?
Tremendous. In all honesty, tremendous. And if we really start to focus on it, we are actually reducing the overall cost of health care by keeping an individual healthier. As we are wanting to do this in our communities, right? We want to do this in our communities with weight reduction and activity and heart disease and diabetes and all this other stuff. We are wanting to go out there into our communities and make them healthier. So when we provide care, our community's health is better. And that's always the goal of any healthcare organization. They're not only thinking within themselves, they're actually thinking of the community that they serve. This is part of the community that we serve. So when we can actually start to provide the care that is needed, the overall cost that some of these healthcare organizations are carrying, because it's an emergent surgery, we have to stabilize, and TALA comes into play, these federal laws. And so when we are doing that and providing care to stabilization, what are we doing afterwards? Are we following through? And so this is, if we were able to follow through and establish where their health gets better, then we are saving our counties, our states, our federal dollars when it comes to healthcare.
And just imagine how much you're empowering that person to seek care again. You know, it's you're breaking a cycle and then, you know, showing them that they are going to be taken care of. And then hopefully that will just continue and they'll get preventative care and can, you know.
Well, you know, and it all starts with that foot in the door experience. So as us as healthcare organizations, we have to become responsible for maybe gender affirming language and educating our staff on it, making sure that we are insistent on clarity and charting, and making sure that we're providing appropriate confidentiality, things to that aspect. But also by not over asking, you know, for maybe some of the surgeries of their anatomy, when they're in there for a flu, why do we need to know about those surgeries and their anatomy changes? Things to that aspect. It's because of curiosity. But what about also as a provider or our medical staff, what about over-examining? Because again, because of our curiosity. But are we setting expectations and standards in healthcare on this? Are we embracing and continuing medical education to our providers, but also our full staff? Everybody needs to have some sort of an updated understanding of the care that is expected. And then we have to also kind of display that outward signs of acceptance. When we start to do that, people are going to start to become more comfortable in their environment that they feared for so long.
We've talked a lot about like nonverbal cues, right? Like our eyes say a lot in the OR. We've had that conversation. Yeah. And it's true. You can say the right things, but if you're not looking them in the eye, or your eyes start to wander, or the look on your face doesn't match the tone of your voice, you know, all of those things are going to send mixed messages to your patients.
That's very true.
Yeah.
You know, there's those holistic care principles that we should all be providing to our patient population. And one is just their chosen name and gender identity for this population. And the other is creating a safe environment, using gender affirming approach, and then even room assignments can become part of this. And then once we get into that perioperative care, it really starts to become another task at hand, because then we, as advocates in the operating room, our surgical technologists, our surgeons, our anesthesiologists, and our circulating and scrub nurses, we have to make sure that we have a good understanding of the anatomy of that patient. That's when those questions start come in. But also, what about their details on their considerations of maybe urinary catheter sizes? What about their airway management or the use of binders that some of our population uses? So if a transgender patient has undergone gender confirming surgery in the past, and that it involved that urethra, such as a vaginoplasty or a phalloplasty, and they've had the urethral lengthening, the placement of a urinary catheter may necessitate using a smaller catheter. So do we have that on hand? You know, things to that aspect that circulating nurse or that person that's involved in this case really has to start to understand. In most circumstances, a urologist will have to come in and insert the catheter on those patients that may have had surgeries before. But when we start to think about like transgender women who may have completed a laryngoplasty or a chondroplasty to alter their voice pitch, the risk of these procedures include the vocal cord damage, reduction of the tracheal lumen or stenosis, dysphagia, tracheal perforation. And so these are important details that we have to make sure that we're advocating for with anesthesia so they have that knowledge. So we have to really focus on that intraoperative airway management that necessitates the caution during that intubation. And then lastly, transgender men who do not transgender men who have not undergone that gender-confirming assignment, or they often utilize those breast binders or those chest wraps. And so when they go through a surgery, we have to make sure that we put that into their post-surgical care, that they may not be able to utilize that binder for 6 weeks or more. And so you're taking away some of their identity, but it's for safety. And so we have to build that into our conversation too. We have to have a very upfront, honest conversation sometimes that makes them uncomfortable. And gosh knows, sometimes it makes us uncomfortable too. But if we start to think about that, it creates a clearer explanation of the care that we can provide to our patients.
Yeah, and I think approaching that conversation from a standpoint that, I recognize that it's going to be uncomfortable for me, and I might be discussing some topics that are uncomfortable for you, the patient, but ultimately I am expressing my goal for you to have a positive outcome and a safe outcome in surgery. I think that it's worth it to go through those uncomfortable conversations approached from a place of the common goal of a safe outcome versus the conversations that get uncomfortable because I've come into it with my implicit or explicit bias or judgment or anything that doesn't even take the patient into consideration. But if my conversation, while it's uncomfortable, is actually taking the patient's experience and the patient's outcome into account in a caring manner, then we can get through the uncomfortable conversations and hopefully help educate them on what's going to be best for their care so they can have the outcome they're looking for. But I never would have thought about the binders. Never would have thought about that until you brought it up. Or the size of the catheter. I would not have thought. I would have just grabbed my Foley pack and gone and then maybe been surprised that I needed something different. So those are the things that we need to think about, and they're good to be aware of.
Yeah, well, also it's like hormone therapy, how some of our anesthetics may play into that. And so those are things that we as nurses need to make sure that we communicate with our anesthesia team just to verify, do you know that this patient is taking this? And do you already have everything that you need in case there's a reaction? Do I need to get anything? Do I need to have anything on backup here? But also, this is where that interdisciplinary multimodal approach really becomes so important on this, because I work in a teaching facility. So there was oftentimes after the procedure when we went to speak to the patient, I, as an advocate, would say, do you know how to approach this patient the best? What is your communication? This is going to be a great learning opportunity for you. Would you like me to come along with you? I have a transgender daughter, and maybe I can support you in this.
And I would say, yes, please. I don't want to.
This is where, when you start to build champions in your arena, this is where it becomes a safer environment for that patient.
Yeah. Well, and when I started practice, a very long time ago, we didn't have these training opportunities.
Ladies and gentlemen, if you were to see her, you would never say that she would say a very long time ago.
I really love you. Really. We're going to have you on for a 10th and 12th time. But no, I mean, I'm 48. I've been in the OR for 20 years, and it's 20 years ago, it was all procedural. You need meds here. You need a 2O Vicryl here. You need, 2 hemostats and this, those things. The training wasn't a holistic approach, and it wasn't about those considerations. It's the, steps 1, 2, 3, 4, 5. So incorporating these types of training annually for everyone at the facility, I think is vital, because we're learning more about different patient populations and more about the care, especially as these surgical procedures are being developed, to be able to give them the identity that they want and the physical, appropriateness for that. So the considerations from a physical standpoint, that both of us never would have thought about.
As caregivers also, we have to think about, in this patient population, what about fillers? Were they medical, or did they come from a automobile manufacturer?
Oh, I watched a documentary on that. There are people that will get a BBL in a back room of a hotel. Oh, it's awful. Don't get me started on my crime stuff, Melanie. You know I am.
But when we start to think about that, that's where we're advocating. Those are those tough, honest questions that we ask. And we just say, I'm asking this for your safety. The more knowledge I have, the better care we can give, because I want to make sure that you make it through this and you are supported and all this, everything else that comes along with that. Making sure that we have full knowledge. I mean, do you have tire inflation foam in your derriere? Do you have, self-injected saline that you made in your kitchen microwave? That's when you're reusing a needle. Things to that aspect.
Caulking silicone
in your lips. Yes.
Yeah. Oh yeah.
Oh, that's terrifying.
So, that all starts to be when you have things like caulking a silicone in your lip injections, and that you are in intubation for quite a while. Imagine how that may set and transform your look.
Yeah, just infection rate. The OCD and germaphobe in both of us are dying.
Well, then there's just the overall effect to your health.
Awful.
Your body was not made to be able to support caulk that I would put on the wall, or tire foam, or homemade saline is not safe. I mean, and it goes back to where we talked about at the beginning, a patient population that feels marginalized, that feels judged, and that feels unaccepted when they come to get healthcare. So they don't. And what do? Sometimes they take matters into their own hands, which then leads to a further detriment in their health. And that's unfortunate. We don't all have to agree. I've said this on multiple episodes. We all don't have to agree on everything, but where we do need to agree is that we can provide compassionate care, and we can take the patient that we have in front of us and care for them in the way that is best for them. And we can set anything else aside to provide that best care, but we need to be educated in order to provide that care. So I think that we've learned a lot.
I learned a lot, and there's still so much to learn,
as we have these conversations. But this is where it starts. It starts with having an open-minded conversation so that we can understand, and then we can move forward and do better. But as we bring this conversation to a close, JD, the mic is always the guests at the last. So please tell us anything else you would like to leave us with before we close.
Well, one thing I've already said is that you have to hold yourself accountable to hold your healthcare system accountable for all these populations. And so as I speak to this one because of my personal experiences, so it becomes a platform for me. I think that when I opened that door to understanding, it really made me grow as a healthcare professional. And so that's what I always ask anybody to do, is allow yourself to open an uncomfortable door, because what you learn may be beneficial for you in the long run. And, that's what I'm going to leave it with. That's some good grandma advice. So.
That is the best takeaway, and it's very applicable. So JD, thank you so much for joining us yet again for another great episode. We appreciate you sharing your passion and your expertise with us.
I greatly appreciate it, and thank you so very much.
That was JD Buchert, Director of Workforce Safety at Parkland Health in Dallas, Texas. And Chris, I know that this topic makes some people uncomfortable. It's kind of like we talked about in episode 1. It's different. Sometimes this is outside of our norm, so to speak. But regardless of that, our transgender patient population is still a patient population that we have to take care of. And the statistics he gave were heartbreaking. And I mean, over 70% use the ER for primary care because of the discrimination and harassment they experience. That's not okay.
Yeah. Well, and at the end of the day, like, things that make you uncomfortable are not to be, so what? Like, everything, good grief, a knife sticking out of our patient's abdomen is going to make them uncomfortable. Like, comfort isn't the point here. Like, the point is that we have a job to do, and that is to take excellent care of our patients. And sterile technique and doing the right thing could, they're blind. It doesn't matter. Like, you have to put your own sense of what is right and what is wrong and what is, correct. It doesn't matter. Like, these patients deserve excellent care, and we have to train our colleagues in our facilities on what excellent care looks like. And JD made some great points, and that's a great start to doing this.
Yeah, it is. Education, awareness, and also self-examination, kind of like we talked about with Darlene Murdoch, taking a look at ourselves, seeing what it is that makes us uncomfortable, and then addressing that and being able to move past it so that we can provide care, because every patient deserves to feel seen and heard and deserves to feel safe when they come into the hospital environment. And I think you're right. It's having conversations like this, understanding it, educating, learning is a good step forward in making sure that we can provide that care to everybody. And that is really going to tie this episode up and bring us to the end of today's interview. So on behalf of Chris, myself, and our whole team, thanks for listening to this week's episode of First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.